Welcome to the 2026 AHIP Medicare Insurance Training. In this first module, we'll provide an overview of the key components that every Medicare agent must understand before selling, discussing, or advising on Medicare products. This foundational knowledge ensures you can serve clients accurately and remain compliant with federal guidelines. We'll begin by reviewing the Medicare Program Basics, covering how the program was established, what it provides, and the different parts of Medicare, including Part A, Part B, Part C, and Part D. Understanding these basics sets the groundwork for every topic that follows. Next, we'll examine Medicare eligibility, enrollment, entitlement, and premiums. You'll learn who qualifies for Medicare, when and how they can enroll, and how premium amounts are determined. This section is essential for helping clients navigate their Medicare options and avoid penalties. From there, we'll cover help for individuals with limited income. This portion explains programs such as Medicaid, the Medicare Savings Programs, and Extra Help, which assist beneficiaries with paying premiums, deductibles, and prescription drug costs. We'll then discuss Original Medicare Cost-Sharing, focusing on the deductibles, coinsurance, and copayments that beneficiaries are responsible for under Parts A and B. A clear understanding of cost-sharing helps you explain coverage gaps and the value of supplemental options. Following that, we'll go over Original Medicare Beneficiary Protections. This section outlines the rights and safeguards built into the Medicare program, including protections against discrimination, access to appeals, and guaranteed issue rights. Next, we'll review Medigap Coverage, also known as Medicare Supplement Insurance. You'll learn how Medigap policies work alongside Original Medicare, what they cover, and when individuals are eligible to enroll. Finally, we'll examine Medicare coordination with Employer Group Health Plans, or GHPs. You'll learn how Medicare interacts with other insurance coverage, including when Medicare is primary or secondary, and how coordination of benefits is determined. By the end of this module, you'll have a strong understanding of the Medicare program's structure, eligibility, costs, and protections, providing a solid foundation for the more advanced compliance and plan-specific training to come. Medicare Basics. Medicare is the federal health insurance program that provides coverage primarily for individuals who are age 65 and older. It also extends to certain younger individuals who qualify due to a disability or because they have specific medical conditions such as end-stage renal disease or amyotrophic lateral sclerosis. Medicare coverage can be obtained in two primary ways. The first is directly through the federal government under what is known as Original Medicare, sometimes referred to as fee-for-service Medicare. Under this model, the government pays health care providers directly for each covered service an individual receives. Beneficiaries can visit any doctor, hospital, or other provider in the United States that accepts Medicare, and no referrals are required. The second way to receive Medicare coverage is through a private health plan that contracts with Medicare. These plans are known as Medicare Advantage, or Part C plans. Medicare Advantage plans are offered by private insurance companies approved by Medicare and must provide all Part A and Part B benefits. Many of these plans also include prescription drug coverage and additional benefits that Original Medicare does not provide, such as dental, vision, or hearing services. It is important to note that Medicare eligibility itself is not based on income. Instead, eligibility is determined primarily by age, disability status, and work history under Social Security or the Railroad Retirement Board. However, income can affect how much a person pays for their coverage. Individuals with higher incomes may pay increased premiums for Part B and Part D coverage, while those with limited income and resources may qualify for financial assistance programs that help pay premiums and out-of-pocket costs. Even if a beneficiary receives their medical coverage through Original Medicare, Prescription drug coverage, known as Part D, is only available through private health plans that have contracts with Medicare. This means that all individuals who wish to have outpatient prescription drug coverage must enroll in a Medicare-approved private plan, whether that plan is a standalone Part D prescription drug plan or a Medicare Advantage plan that includes drug benefits. Understanding these foundational points is essential, as they establish the framework for how individuals qualify for Medicare and how their coverage is delivered, administered, and paid for. To understand how Medicare operates today, it's helpful to look at how the program began and how it has evolved over time. Medicare was established in 1965 under Title 18 of the Social Security Act. When it first began, it was a simple fee-for-service program, now known as Original Medicare. Under this structure, beneficiaries could receive health care services from any provider or facility that accepted Medicare, and the federal government would pay those providers directly for each covered service through its designated administrative contractors. This design offered beneficiaries broad flexibility and nationwide access to care. Over time, Medicare expanded to include private plan options. Congress recognized the value of managed care delivery models, which could help coordinate care and potentially lower costs. As a result, beneficiaries were given the option to receive their Medicare-covered benefits through managed care plans, private health plans that contract with Medicare and operate within specific provider networks. These plans are known today as Medicare Advantage or Part C plans. A major milestone in Medicare's evolution came in 2006, when the program began offering outpatient prescription drug coverage through private health plans. This benefit, known as Part D, allows beneficiaries to obtain coverage for self-administered prescription drugs, typically through standalone prescription drug plans or Medicare Advantage plans that include drug coverage. Each of these changes, from the original fee-for-service model to the introduction of managed care plans to the addition of prescription drug coverage, represents an important step in Medicare's continuing effort to provide comprehensive and accessible health coverage to older adults and individuals with disabilities. Let's now review the core benefits and coverage provided under Medicare. Medicare benefits are divided into distinct parts, each authorized under separate sections of federal law. These are commonly referred to as Parts A, B, C, and D. Parts A and B together form the foundation of Medicare coverage and are often called Original Medicare. Regardless of whether an individual receives their benefits directly through Original Medicare or through a Medicare Advantage plan, Parts A and B define the basic set of services every beneficiary is entitled to. We'll begin with Part A, which is known as hospital insurance. Despite the name, Part A covers a variety of inpatient and facility-based services, as well as certain home health and hospice care. Part A provides coverage for several key types of care. First, it covers inpatient hospital care. This includes services provided in acute care hospitals, critical access hospitals, inpatient rehabilitation facilities, and long-term care hospitals. These settings address different levels of medical need, but all are considered inpatient services under Medicare Part A. Second, Part A covers the cost of blood used during a transfusion while a patient is hospitalized. Beneficiaries are generally responsible for the cost of the first 3 pints of blood unless the blood is donated to the hospital or replaced by a community blood drive. Third, Part A provides coverage for home health care services for up to 100 days following a qualifying hospital or skilled nursing facility stay. These services can include part-time skilled nursing care, physical therapy, occupational therapy, and speech-language pathology services. It's important to note that if a patient needs home health care without a prior hospital or skilled nursing facility stay, those services may instead be covered under Part B, provided the eligibility requirements are met. Fourth, Medicare Part A covers skilled nursing facility and rehabilitation care for up to 100 days, but this coverage applies only after a beneficiary has spent at least 3 consecutive days as an inpatient in a hospital. Medicare Advantage plans may waive the 3-day hospital stay requirement depending on plan rules. Fifth, Part A includes hospice care for individuals with a terminal illness who have a life expectancy of 6 months or less. Hospice services focus on comfort, pain management, and emotional support rather than curative treatment, and they can be provided in a patient's home, a hospice facility, or another inpatient setting. Lastly, Part A covers inpatient psychiatric care, but this coverage is limited to a lifetime maximum of 190 days in a freestanding psychiatric hospital. Psychiatric services provided in general hospitals do not count toward this limit. Together, these Part A benefits make up the foundation of hospital and facility-based coverage under Medicare. Understanding the details and limits of each benefit is critical for advising clients accurately, identifying coverage gaps, and explaining how supplemental insurance, such as Medigap or Medicare Advantage, can enhance their protection. Next, let's move to Part B of Medicare, known as Supplementary Medical Insurance Benefits. While Part A primarily covers inpatient and facility-based care, Part B provides coverage for a wide range of outpatient and physician services. Together, Parts A and B make up the core benefits of original Medicare. Part B covers medically necessary services that are needed to diagnose or treat a medical condition, as well as many preventive services that help detect illnesses early or manage chronic conditions. Beneficiaries who enroll in Part B generally pay a monthly premium, and coverage is optional for most individuals. Under Part B, Medicare generally covers physician and other healthcare professional services. This includes visits to doctors, specialists, nurse practitioners, and other qualified practitioners for evaluation and treatment, whether performed in an office, clinic, or hospital outpatient setting. Outpatient hospital services. These are services provided at a hospital when a patient is not admitted as an inpatient. Examples include emergency department care, observation services, and minor surgical procedures performed in an outpatient setting. Clinical laboratory and diagnostic tests. This includes laboratory tests such as blood work, as well as diagnostic imaging such as X-rays, MRIs, and CT scans used to evaluate medical conditions. Durable medical equipment, or DME. Part B helps pay for medically necessary equipment prescribed by a doctor for use in the home. Examples include wheelchairs, walkers, hospital beds, oxygen equipment, and continuous glucose monitors, home health care that is not covered under Part A. This applies when a beneficiary has not recently been in a hospital or skilled nursing facility, or when the 100-day Part A limit has been reached. Services may include intermittent skilled nursing care and physical, occupational, or speech therapy for homebound individuals who meet Medicare's eligibility criteria. Physical and occupational therapy, as well as speech-language pathology services, are covered when they are medically necessary to restore or maintain physical function following an illness, injury, or surgery. Ambulatory surgical center services. These are same-day surgical procedures performed outside of a hospital setting. Medicare covers these services when they are performed in a Medicare-certified ambulatory surgical center. Chemotherapy and other outpatient drug administration. Part B covers certain prescription drugs that are administered in a physician's office or hospital outpatient department, such as cancer treatment infusions or injectable medications that cannot be self-administered. Through these benefits, Part B plays a critical role in covering the ongoing, outpatient, and preventive care that most beneficiaries rely on throughout the year. Together with Part A, it provides the essential framework of original Medicare coverage, forming the foundation upon which supplemental and Medicare Advantage plans are built. Part B of Medicare covers several additional medical services and supplies that are essential to the ongoing care and treatment of beneficiaries. These services may not require inpatient hospital admission, but are medically necessary to diagnose, monitor, or treat health conditions. Examples of covered services include ambulance services, coverage for emergency transportation to the nearest appropriate medical facility when other transportation could endanger the individual's health, chiropractic services, limited to manual manipulation of the spine to correct a subluxation when one or more bones in the spine are out of position. Opioid use disorder treatment includes medication-assisted treatment, such as methadone or buprenorphine, counseling, and other related services provided in approved settings. Preventive health services includes screenings, vaccinations, such as flu and pneumonia shots, mammograms, smoking cessation counseling, and other preventive measures. Many of these services do not require any cost sharing. Diabetic supplies. Coverage includes blood glucose monitors, test strips, lancets, and other related supplies necessary for diabetes management. Kidney dialysis, end-stage renal disease services. Coverage for outpatient dialysis treatments, including necessary supplies and certain related drugs. Outpatient mental health care includes therapy, counseling, and other outpatient mental health services. Some limits may apply to frequency or duration of services. Virtual check-ins, telehealth services, allows beneficiaries to communicate with their healthcare provider using video or audio technology for certain non-emergency medical consultations. Continuous positive airway pressure, CPAP. Devices. Coverage for CPAP therapy equipment used to treat obstructive sleep apnea when medically necessary and prescribed by a qualified provider. Next, we will discuss Part C, which governs Medicare Advantage plans. Medicare Advantage plans are private health plans that contract with the federal government to provide and manage Medicare benefits. These plans offer an alternative to original Medicare by combining Part A and Part B coverage into a single plan. All Medicare Advantage plans are required to cover the same services provided under Part A and Part B, with the exception of hospice care. Beneficiaries enrolled in a Medicare Advantage plan still receive hospice benefits through original Medicare, ensuring that end-of-life care is fully covered. In addition to standard Medicare benefits, Medicare Advantage plans may offer coverage for services not included in original Medicare. Examples can include vision, dental, hearing, wellness programs, and sometimes prescription drug coverage if included in the plan. The exact benefits and plan rules, such as provider networks and cost-sharing requirements, may vary depending on the plan selected. By offering both the standard Medicare benefits and optional supplemental services, Medicare Advantage plans provide beneficiaries with the flexibility to select a plan that fits their healthcare needs and budget. Now, let's turn to Part D, which provides Medicare prescription drug coverage. Part D covers self-administered prescription drugs, meaning medications that beneficiaries obtain from a pharmacy and take at home. This coverage is designed to help lower the cost of outpatient prescription medications and improve access to necessary treatments. Part D benefits are only available through private health plans that contract with Medicare. These plans include certain Medicare Advantage plans that offer prescription drug coverage in addition to Parts A and B benefits. Some Medicare cost plans, which combine aspects of original Medicare and private plan administration. PACE plans, or programs of all-inclusive care for the elderly, which may include prescription drug coverage as part of their comprehensive benefits. Standalone Medicare prescription drug plans, often referred to as PDPs, which provide drug coverage separately from original Medicare. It is important to note that all beneficiaries who want outpatient prescription drug coverage must enroll in a Medicare-approved Part D plan, even if they receive their medical benefits through Original Medicare. This ensures that their medications are covered and that they can access the protections and cost-sharing rules established under Medicare law. Part D plays a critical role in helping beneficiaries manage the cost of prescription medications, complementing the medical coverage provided under Parts A and B, and supporting the overall goal of comprehensive Medicare coverage. In addition to Parts A through D, there is a lesser-known provision of Medicare law often referred to as Part E. This section of the law governs several miscellaneous programs that provide additional coverage options or specialized care for certain populations. One example is Medicare Cost Plans, which are private health plans that provide Medicare benefits similar to Original Medicare, including Part A and Part B coverage. Cost plans are available in a limited number of states, and they are most commonly offered in rural areas where access to providers may be more restricted. These plans may also offer Part D prescription drug coverage, depending on the specific plan. Another program regulated under Part E is Medicare Supplemental Insurance, commonly known as Medigap. Medigap policies are sold by private insurers and are designed to fill gaps in Original Medicare coverage, including deductibles, coinsurance, and certain copayments. Medigap plans provide beneficiaries with greater financial predictability and broader access to health care services. Finally, Part E includes oversight of the Program of All-Inclusive Care for the Elderly, or PACE. PACE is a comprehensive care program for adults age 55 and older who require nursing home-level care but wish to remain in the community. PACE provides medical, social, and long-term care services, coordinating care through a single organization to meet the beneficiary's needs. While these programs are not as widely utilized as Medicare's main parts, understanding them is important for advising beneficiaries who may qualify or benefit from these additional options. Now that we have reviewed the different parts of Medicare and the benefits they provide, let's discuss the various ways beneficiaries can receive their Medicare coverage. The first option is Original Medicare, which includes Part A and Part B benefits. Under Original Medicare, beneficiaries may access covered services from any physician, hospital, or other provider that accepts Medicare anywhere in the United States. There are no referrals required, providing beneficiaries with broad flexibility and freedom of choice. However, Original Medicare comes with substantial deductibles and cost-sharing obligations. To help manage these out-of-pocket costs, beneficiaries may choose to supplement Original Medicare with a Medicare Supplement Plan, also known as Medigap, and/or a standalone Medicare Prescription Drug Plan, which provides coverage for outpatient prescription medications. The second option is a Medicare Advantage Plan, or Part C. Medicare Advantage plans are private health plans that contract with Medicare to provide Part A and Part B benefits. Some Medicare Advantage plans also include Part D prescription drug coverage, as well as additional benefits such as vision, dental, or wellness programs. These plans often operate within provider networks and may have different cost-sharing rules compared to Original Medicare. Third, beneficiaries may enroll in a Medicare Prescription Drug Plan, or PDP, if they wish to add outpatient prescription drug coverage to Original Medicare or certain Medicare cost plans. Fourth, Medicare cost plans provide Medicare benefits through private plans and cover Part A and Part B services, often combined with prescription drug coverage. These plans are more limited in availability and are typically offered in specific geographic areas. Finally, there is the Program of All-Inclusive Care for the Elderly, or PACE. PACE is designed for adults aged 55 and older who need nursing home-level care but wish to continue living in their community. PACE provides comprehensive medical, social, and long-term care services, coordinating care through a single organization to meet all of the beneficiaries' needs. By understanding these options, you will be able to guide beneficiaries in selecting the Medicare coverage that best fits their healthcare needs, lifestyle, and financial circumstances. Medicare eligibility, enrollment, entitlement, and premiums eligibility. In this section, we will review eligibility requirements for Medicare Part A and Part B. Understanding who qualifies for Medicare is fundamental to helping beneficiaries access coverage at the appropriate time. To be eligible for Medicare Part A and Part B, an individual must meet the following criteria. First, the individual must be age 65 or older, or under age 65 with specific disabilities or health conditions. This includes individuals who have been receiving disability benefits from Social Security for at least 24 months, or certain disability benefits from the Railroad Retirement Board. Individuals diagnosed with amyotrophic lateral sclerosis, or ALS, often referred to as Lou Gehrig's disease. Individuals with end-stage renal disease, or ESRD, which typically requires dialysis or a kidney transplant. Second, the individual must be a U.S. resident, which requires either being a U.S. citizen or being a lawfully admitted alien who has maintained permanent residence in the United States for at least 5 continuous years prior to applying for Medicare. Meeting these requirements establishes a person's entitlement to Medicare Part A and Part B. Eligibility is the first step in the enrollment process, and it is important for beneficiaries to understand when they qualify so they can avoid coverage gaps or late enrollment penalties. In this section, we will review eligibility requirements for Medicare Part A and Part B. Understanding who qualifies for Medicare is fundamental to helping beneficiaries access coverage at the appropriate time. To be eligible for Medicare Part A and Part B, an individual must meet the following criteria. First, the individual must be age 65 or older, or under age 65 with specific disabilities or health conditions. This includes individuals who have been receiving disability benefits from Social Security for at least 24 months, or certain disability benefits from the Railroad Retirement Board. Individuals diagnosed with amyotrophic lateral sclerosis, or ALS, often referred to as Lou Gehrig's disease. Individuals with end-stage renal disease, or ESRD, which typically requires dialysis or a kidney transplant. Second, the individual must be a U.S. resident, which requires either being a U.S. citizen or being a lawfully admitted alien who has maintained permanent residence in the United States for at least 5 continuous years prior to applying for Medicare. Meeting these requirements establishes a person's entitlement to Medicare Part A and Part B. Eligibility is the first step in the enrollment process, and it is important for beneficiaries to understand when they qualify so they can avoid coverage gaps or late enrollment penalties. We will now review Medicare eligibility and enrollment for individuals with special health conditions, as well as the general enrollment rules for Parts A and B. Individuals with end-stage renal disease, ESRD. Individuals who qualify for Medicare based on ESRD are generally eligible for Medicare coverage for 36 months following the month of a kidney transplant, unless they qualify under another basis, such as age or disability. After this period, they may continue to remain enrolled in Part B only, but solely for coverage of immunosuppressive drugs, provided they have no other health insurance that would cover these medications. Individuals with amyotrophic lateral sclerosis, ALS, individuals diagnosed with ALS, also known as Lou Gehrig's disease, are automatically enrolled in Parts A and B in the same month their Social Security disability benefits begin. This ensures that they have immediate access to comprehensive Medicare coverage as soon as they are deemed disabled. Automatic enrollment for age or disability. Some individuals are automatically enrolled in Medicare Parts A and B. Individuals already receiving Social Security or Railroad Retirement Board benefits will be automatically enrolled in Parts A and B beginning the first day of the month they turn 65. If their birthday falls on the first day of the month, coverage begins the first day of the prior month. Beneficiaries may choose to refuse Part B coverage, although doing so may have future consequences. Individuals under age 65 who receive Social Security or Railroad Retirement Disability benefits are automatically enrolled in Parts A and B in the month following 24 months of disability benefits. They also have the option to refuse Part B coverage. Individuals living in Puerto Rico are an exception. They are not automatically enrolled in Part B and must sign up separately. Initial enrollment period for other individuals. Those who are approaching age 65 but not yet receiving Social Security or Railroad Retirement benefits must actively sign up for Parts A and B during their initial enrollment period, which begins 3 months before their 65th birthday, includes the month they turn 65, and ends 3 months after their birthday month. Failure to enroll in Part B when first eligible may result in late enrollment penalties and gaps in coverage. Special enrollment for individuals with ESRD. Individuals with ESRD may sign up for Medicare at any time. Generally, coverage begins on the 4th month after dialysis treatments begin, although it may start earlier under certain circumstances. Coverage start for Part A. Individuals eligible for premium-free. Part A may sign up at any time after turning 65. Part A coverage may start 6 months prior to enrollment, but not earlier than the month they turned 65. If a beneficiary applies for Social Security benefits, they will be automatically enrolled in Part A, and coverage is retroactive for up to 6 months, ensuring there are no gaps in hospital coverage. Understanding these rules is essential for advising beneficiaries about enrollment timing, avoiding penalties, and ensuring continuous access to care. Next, we will discuss enrollment in Medicare Parts A and B after the initial enrollment period, including general and special enrollment opportunities. Individuals who do not enroll in Part B or in Part A if they must purchase it, during their initial enrollment period, may enroll during the annual General Enrollment Period, or GEP, which occurs each year from January 1st through March 31st. Coverage begins the first day of the month, following the month in which the beneficiary enrolls. There are also Special Enrollment Periods, or SEPs, which allow individuals to enroll in Parts A and/or B outside the standard enrollment windows under certain circumstances. For example, individuals with group health plan coverage through their current employment or the employment of a spouse may delay enrollment in Part A or Part B without penalty. They can sign up at any time while covered under the group health plan, or during the 8-month period following the end of the group coverage. Special enrollment periods may also apply in cases such as emergencies or federally declared disasters in the beneficiary's area. Release from incarceration, loss of Medicaid coverage, another health plan, or employer-sponsored coverage. Errors by a health plan or employer that cause the individual to miss the initial enrollment period. Other exceptional circumstances deemed valid by Medicare. Individuals who are eligible for premium-free Part A may also enroll at any time, providing additional flexibility for beneficiaries who initially chose to delay enrollment. Understanding the timing and conditions for these enrollment periods is crucial. It helps ensure that beneficiaries can access coverage when they need it, while avoiding late enrollment penalties and gaps in hospital or medical coverage. Next, let's review the rules regarding entitlement to Medicare Part A and enrollment in Part B. An individual is entitled to Part A if they meet one of the following conditions. They are eligible for premium-free Part A, meaning they qualify based on sufficient work credits from Social Security or Railroad Retirement, or they have enrolled in Part A and continue to pay the required premium, either directly or through another entity, such as an employer or government program, that covers the premium on their behalf. For Part B, enrollment is optional, but coverage can only be maintained if the individual pays the Part B premium, either directly or through an arrangement where the premium is paid on their behalf. Failure to pay the premium will result in termination of Part B coverage. In other words, entitlement to Part A is largely automatic for those eligible, while Part B requires active enrollment and ongoing premium payment. Beneficiaries must understand these distinctions to ensure uninterrupted coverage and avoid gaps in their Medicare benefits. In addition to Original Medicare, beneficiaries may receive coverage through other Medicare programs, including Medicare Advantage Part C, Medicare Prescription Drug Plans, Part D, Medicare Cost Plans, and PACE plans. Each of these options has specific eligibility requirements that must be met. To enroll in a Medicare Advantage plan, an individual must first be entitled to Medicare Part A and enrolled in Medicare Part B. In addition, the individual must live within the plan's service area, which is defined by the network of providers that participate in the plan. Medicare Advantage plans may offer additional benefits that are not included in Original Medicare, such as coverage for vision, dental, and wellness programs. Enrollment in a Medicare prescription drug plan, or Part D, requires that an individual be entitled to Part A and/or enrolled in Part B. The individual must also reside within the plan's service area to be eligible for enrollment. Part D plans provide coverage for outpatient prescription medications and may be offered as standalone prescription drug plans or included as part of a Medicare Advantage plan. To participate in a Medicare cost plan, an individual must be entitled to Medicare Part A and/or enrolled in Part B. If the individual is not entitled to Part A, they will not have coverage for Part A benefits under the cost plan. In addition, the individual must reside within the plan's service area. Medicare cost plans are typically offered in limited geographic regions and combine elements of Original Medicare with administration through a private plan. The Program of All-Inclusive Care for the Elderly, or PACE, is designed for older adults who require nursing home-level care but wish to remain in the community. To be eligible for PACE, an individual must be at least 55 years old, be certified by the state as eligible for nursing home care, be able to live safely in a community setting at the time of enrollment, reside within the PACE organization's service area, and meet any additional program-specific eligibility conditions outlined in the plan's PACE program agreement. Understanding these eligibility requirements allows advisors to guide beneficiaries in selecting the Medicare coverage that best meets their needs while ensuring compliance with program rules. Next, we will review Medicare Part A premiums and how they are determined. For most individuals, Medicare Part A is provided premium-free. To qualify for premium-free Part A at age 65, the individual or their spouse must have worked and paid Medicare taxes for at least 10 years, which is equivalent to 40 quarters of work. Additionally, all individuals who are eligible for Medicare due to disability, end-stage renal disease, or amyotrophic lateral sclerosis automatically qualify for premium-free Part A, regardless of work history. For those who do not automatically qualify for premium-free Part A, a monthly premium is required. As of 2025, the premiums are $518 per month for individuals or spouses who have paid Medicare taxes for less than 30 quarters, and $285 per month for those who have paid Medicare taxes for 30 to 39 quarters. It is important to note that individuals who are not eligible for premium-free Part A and who do not purchase Part A when first eligible may be subject to a late enrollment penalty. This penalty can be up to 10% of the monthly premium and is applied for twice the number of years the individual could have had Part A but did not enroll. Beneficiaries should carefully consider their eligibility and enrollment timing to avoid unnecessary penalties and ensure uninterrupted hospital coverage. Next, we will review Medicare Part B premiums. All beneficiaries enrolled in Part B are required to pay a monthly premium. For 2025, the standard Part B premium is $185 per month. Most beneficiaries pay this standard premium. However, some individuals with higher income may pay an adjusted premium. These income-related adjustments, known as Income-Related Monthly Adjustment Amounts, IRMAA, are calculated based on the individual's modified adjusted gross income reported to the IRS 2 years prior. In this case, 2023 income is used to determine 2025 premiums. It is important for beneficiaries to understand that Part B premiums are separate from Part A and must be paid monthly to maintain coverage. Failure to pay Part B premiums can result in termination of coverage and may require re-enrollment during a later period, potentially with a late enrollment penalty. By understanding Part B premium rules, beneficiaries can make informed decisions regarding coverage and budgeting for their healthcare costs. In 2025, the standard monthly premium for Medicare Part B is $185. Beneficiaries whose modified adjusted gross income, MAGI, from 2 years earlier exceeds certain thresholds pay more than the standard premium under the Income-Related Monthly Adjustment Amount, IRMAA. For 2025, those thresholds begin at a MAGI of over $106,000 for individuals or over $212,000 for married couples filing jointly. For 2026, the standard premium is projected to increase to approximately $206.50 per month. By understanding your MAGI and these premium brackets, you'll be better able to anticipate what your Part B premium may be. Next, we will discuss how Medicare Part B premiums are paid and the rules for late enrollment penalties. Part B premiums are typically collected in several ways. For most beneficiaries, the premium is automatically deducted from their Social Security checks, railroad retirement checks, or Office of Personnel Management civil service annuity checks. If a beneficiary does not receive any of these payments, Medicare will issue a premium bill every 3 months. In some cases, employers may pay the Part B premium on behalf of retirees. Individuals who do not enroll in Part B when they are first eligible may face a late enrollment penalty. This penalty increases the Part B premium by 10% for each full 12-month period that the individual could have had Part B but did not enroll. The penalty continues for as long as the individual remains enrolled in Part B. There are exceptions to this rule. Individuals who have group health plan coverage based on their current employment or the employment of a spouse are not subject to the late enrollment penalty if they enroll in Part B while still covered under the group health plan or during the special enrollment period, which occurs within 8 months after the last month of group coverage. Additionally, individuals who enroll in Part B during any other approved special enrollment period are also exempt from the penalty. Understanding these payment mechanisms and potential penalties helps beneficiaries avoid unexpected costs and ensures that their Part B coverage remains uninterrupted. To help illustrate how Medicare Part B premiums and late enrollment penalties work, let's look at 2 examples. Example 1. Mr. Thompson retired at age 70. While working, he had full coverage through his employer's health plan, and therefore did not enroll in Part B when first eligible. Because he had creditable employer coverage, Mr. Thompson can enroll in Part B within 8 months after his employer insurance ends without facing a late enrollment penalty. Example 2. Mrs. Alvarez retired at age 67. Before retirement, she worked part-time but did not qualify for employer-sponsored insurance. She purchased a short-term health plan for limited coverage, thinking it was sufficient alongside Medicare Part A. After retirement, she developed hypertension and other chronic conditions requiring regular doctor visits and lab work. Since Mrs. Alvarez did not enroll in Part B during her initial enrollment period and did not have creditable coverage, she can enroll only during the general enrollment period. She will be required to pay the standard Part B premium plus a 10% late enrollment penalty for each full year she delayed enrollment. These examples demonstrate two important principles. Creditably covered individuals can delay Part B enrollment without penalty. Individuals without creditable coverage who delay enrollment must pay higher premiums due to the late enrollment penalty. Help for individuals with limited income. Next, we will discuss programs available to assist Medicare beneficiaries with limited income and resources. Certain beneficiaries with lower incomes and limited assets may qualify for help to pay Medicare Part A and Part B premiums, Part A and Part B deductibles and cost-sharing, and some Part D prescription drug costs. These assistance programs are typically managed through the state Medicaid office. One such program is the Medicare Savings Program, which helps eligible beneficiaries pay for Part A and Part B premiums, and, in some cases, also covers deductibles and cost-sharing. One example of this program is the Qualified Medicare Beneficiary Program. Beneficiaries enrolled in Medicare Advantage plans who qualify for QMB also receive help with their Medicare Advantage cost-sharing amounts. The Part D low-income subsidy, also called Extra Help, assists eligible beneficiaries with prescription drug coverage. Individuals seeking assistance with Part D coverage can apply online through the Social Security Administration or by calling 1-800-772-1213. It is important to note that Extra Help is not available in Puerto Rico, the U.S. Virgin Islands, Guam, the Northern Mariana Islands, or American Samoa. Finally, Medicaid can assist with health care costs not covered by Medicare, including services such as custodial or long-term care. Understanding these programs is critical for beneficiaries who need financial assistance to access essential Medicare services and prescription drug coverage. Some beneficiaries who do not qualify for the Part D low-income subsidy but still have limited means may be eligible for assistance with prescription drug costs through their state's Pharmaceutical Assistance Program. Agents should encourage beneficiaries with limited income and resources to contact their state Medicaid office to learn more about Medicare Savings Programs and other available assistance. To find the phone number for a state Medicaid office, beneficiaries can visit medicare.gov/contacts, call 1-800-MEDICARE, or reach out to their State Health Insurance Assistance Program, or SHIP, for personalized guidance and support. Original Medicare Part A includes cost-sharing for inpatient hospital care. In 2025, beneficiaries pay a $1,676 deductible for each benefit period. A benefit period begins the day a person is admitted to a hospital or skilled nursing facility and ends when they have not received hospital or skilled nursing care for 60 consecutive days. For days 1 through 60, there is no daily copayment once the Part A deductible has been met. From days 61 to 90, beneficiaries pay a daily copayment of $419. From days 91 to 150, beneficiaries use what are called lifetime reserve days, with a daily copayment of $838. Each beneficiary has 60 lifetime reserve days that can be used once they have been in the hospital for more than 90 days. After lifetime reserve days are exhausted, the beneficiary is responsible for all costs for additional inpatient days. Original Medicare Cost-Sharing. Part A also covers skilled nursing and rehabilitative care, with cost-sharing that varies by the length of stay. In 2025, beneficiaries pay nothing for the first 20 days of each benefit period. From day 21 through day 100, beneficiaries are responsible for a daily copayment of $209.50. Beyond day 100, the beneficiary is responsible for all costs for additional skilled nursing care. Original Medicare. Part A covers skilled nursing and rehabilitative care with cost sharing that depends on the length of stay. In 2025, beneficiaries pay nothing for the first 20 days of each benefit period. From day 21 through day 100, there is a daily copayment of $209.50. Beyond day 100, beneficiaries are responsible for all costs for additional skilled nursing care. Original Medicare Part B includes cost sharing for outpatient services. In 2025, beneficiaries have an annual deductible of $257. Once the deductible has been met, beneficiaries generally pay 20% of the Medicare-approved amount for most Part B services. It is important to note that there is no cost sharing for most preventive services covered under Part B, allowing beneficiaries to access essential screenings and preventive care at no out-of-pocket cost. Original Medicare. Beneficiary Protections. Beneficiaries receiving Part A or Part B services through Original Medicare have the right to appeal Medicare coverage and payment decisions. Appeals related to Part A or B services must be filed within 120 days of receiving the Medicare summary notice in the mail, which details the beneficiary's financial responsibility and provides instructions on where to submit the appeal. Beneficiaries who believe their hospital, skilled nursing facility, home health agency, comprehensive outpatient rehabilitation facility, or hospice services are ending too soon have the right to request a fast appeal. Providers must give written notice before the end of services, explaining how to request the fast appeal. Generally, beneficiaries must ask for the fast appeal by noon of the calendar day following receipt of the provider's notice of termination. If a beneficiary disagrees with the appeal decision, they have 180 days from the decision notice to request a reconsideration by a qualified independent contractor. Additional levels of appeal may be available depending on the amount in controversy, ensuring beneficiaries have multiple opportunities to resolve disputes regarding their Medicare coverage or payment. Beneficiaries may file complaints about their Medicare providers or the quality of care they received. Complaints can include unprofessional conduct by a provider, improper or unsafe care, abuse by a provider, long waiting times, or unclean conditions. Filing a grievance ensures that beneficiaries have a formal way to raise concerns and seek resolution regarding the services they receive under Original Medicare. Medicare provides a 24-hour helpline at 1-800-MEDICARE. TTY users can call 1-877-486-2048. Beneficiaries can use this number to check the status of claims, learn about coverage and benefits, verify premium payments, or ask any other questions related to Medicare. Additional assistance is available through local state health insurance assistance programs, or SHIPS, which can help beneficiaries navigate Medicare, including support with filing appeals or grievances. Beneficiaries in Original Medicare can receive Part D prescription drug coverage through a standalone prescription drug plan, or PDP. Generally, beneficiaries must actively choose a Part D plan, except for those who are dually eligible for Medicare and Medicaid. Enrolling in Part D usually requires paying a monthly premium, an annual deductible, and cost sharing for each prescription. When selecting a Part D plan, beneficiaries should carefully consider the expected premiums and cost sharing, the plan's formulary, and the network of participating pharmacies to ensure the plan meets their medication needs. Medigap, or Medicare Supplemental Insurance, works only with Original Medicare and cannot be sold to someone enrolled in a Medicare Advantage plan. These plans are offered by private insurance companies to help fill gaps in Original Medicare coverage, including all or part of deductibles and coinsurance amounts. Some Medigap policies also provide limited benefits not covered by Part A or Part B, such as extra days of inpatient hospital coverage or emergency care while traveling abroad. Generally, Medigap does not cover long-term care in a nursing home, vision or dental services, hearing aids, eyeglasses, or private duty nursing. Medigap policies are available in standardized plans, identified by letters A through N, although Massachusetts, Minnesota, and Wisconsin offer different plan structures. Each state determines which standardized plans may be offered within its borders. When an individual turns 65 and enrolls in Part B, it triggers a 6-month Medigap open enrollment period, during which insurers must issue a policy regardless of any pre-existing conditions. This is known as a guaranteed issue, right? In certain limited situations, leaving a Medicare Advantage plan can also trigger a guaranteed issue right. Medigap plan issuance and sales are regulated by individual states, which may have additional guaranteed issue rights, marketing rules, or specific requirements regarding commissions. Agents should be familiar with their state's rules and regulations for Medigap sales to ensure compliance. All Medigap plans cover some or all of certain costs under Original Medicare. This includes Part A coinsurance, coverage for up to 365 additional hospital days once Medicare coverage ends, Part B coinsurance or copayments, the first 3 pints of blood, and coinsurance or copayments for hospice care. These benefits help reduce out-of-pocket expenses for beneficiaries and provide added financial protection beyond what Original Medicare covers. Some Medigap plans, specifically plans H, I, and J, previously offered non-Medicare drug coverage. These plans have not been sold since January 1, 2006, but some beneficiaries may have chosen to keep their policies with drug coverage purchased before that date. Individuals with Medigap plans can only obtain Medicare prescription drug coverage through a standalone Part D plan. Beneficiaries who have plans H, I, or J may either keep their Medigap policy with the drug coverage removed and enroll in a Part D prescription drug plan, or they may drop their Medigap coverage and enroll in a Medicare Advantage plan that includes drug coverage. If a Medigap policy does not provide creditable prescription drug coverage, the beneficiary may face a late enrollment penalty. Creditable coverage means the Medigap policy's drug benefits are, on average, at least as valuable as Medicare's standard Part D coverage for the same prescriptions. Individuals who turn 65 or first become eligible for Medicare due to age, disability, or end-stage renal disease on or after January 1, 2020, cannot purchase a Medigap plan that covers the Part B deductible, which generally includes plans C, F, and high deductible F. This restriction also applies in states with non-standard Medigap packages. However, individuals who were already enrolled in a plan that covers the Part B deductible before this date may remain in their plan. Those who became eligible for Medicare before 2020 may continue to enroll in plans that cover the Part B deductible. Employer Group Health Plans, GHPs. The rules for how employer health plans coordinate with Medicare depend on several factors, including whether the coverage is offered by a large group health plan and whether the individual has coverage through their own or a spouse's current employment. A large group health plan is defined as one with 20 or more employees for each working day in at least 20 calendar weeks during the current or preceding year. These factors help determine whether Medicare or the employer's group health plan pays as the primary coverage for Medicare-eligible individuals. Medicare law prohibits large group health plans from treating individuals or their spouses as entitled to Medicare benefits simply because they are covered under the employer plan through current employment. Large group health plans are also required to provide the same benefits, under the same conditions, to employees and spouses age 65 or older, as they do to those under age 65 who have current employment coverage. This ensures that Medicare-eligible individuals who are still working receive consistent treatment from their employer's health plan. It is illegal for a large group health plan to encourage a Medicare-eligible employee to decline the employer's plan in favor of Medicare, or to offer different coverage than what is provided to employees who are not Medicare-eligible. This includes offering Medicare Advantage or Medigap plans to employees and their spouses. Individuals who have coverage through a large group health plan based on their own or a spouse's current employment may choose not to enroll in Part B when they first become eligible. As long as they maintain their employer coverage, they will not face a late enrollment penalty if they enroll in Part B at a later date. For individuals with group health coverage through their own or a spouse's current employment at a small employer, Medicare serves as the primary payer. The employer is not required to provide coverage for Medicare-eligible employees, and small group health plans are not obligated to offer the same benefits to employees and spouses age 65 or older as they do to younger employees. Small employers may choose to purchase or contribute toward a Medicare Advantage plan for their employees and spouses, or offer Medigap coverage, which is not limited to the standardized plans. Individuals with coverage under a small group health plan should generally enroll in Medicare Part B when they become eligible to ensure proper coordination of benefits. Training Summary. In this module, we covered the fundamentals of Medicare, including the different parts, eligibility requirements, enrollment rules, and costs. We started with Medicare Basics, explaining that it is the federal health insurance program for individuals age 65 and older and for younger individuals with certain disabilities or serious health conditions. We reviewed how beneficiaries can receive coverage through Original Medicare or private plans, and how Part D prescription drug benefits are always provided through private plans. We then detailed the benefits of each Medicare part. Part A covers inpatient hospital care, skilled nursing, home health, hospice, and limited psychiatric care. Part B provides coverage for outpatient services, physician care, durable medical equipment, preventive services, and certain therapies. Part C, or Medicare Advantage, allows beneficiaries to receive all Part A and Part B benefits through private health plans, often with extra benefits, while Part D covers prescription drugs through private plans. We also discussed lesser-known Part E programs, including Medicare Cost Plans, Supplemental Medigap Insurance, and PACE. Next, we reviewed the ways beneficiaries can enroll in Medicare, including automatic enrollment and initial, general, and special enrollment periods. We covered eligibility for Parts A and B, including rules for individuals with disabilities, ALS, and end-stage renal disease, and explained how premiums work. Part A is usually premium-free for those who meet work history requirements, while Part B requires a monthly premium that can increase based on income, with the possibility of late enrollment penalties if coverage is delayed. We illustrated these rules with examples showing how timing and current employment affect enrollment and penalties. We also discussed assistance for individuals with limited income and resources, including Medicare Savings Programs, the Part D Low-Income Subsidy, or Extra Help, Medicaid, and state pharmaceutical assistance programs, and emphasized the importance of contacting state offices or SHIP for help. Original Medicare Cost-Sharing was explained, including Part A hospital and skilled nursing copayments, and Part B outpatient deductibles and coinsurance, along with protections for beneficiaries. We covered appeal rights, grievance procedures, and how Part D coverage is obtained and structured. Medigap, or Medicare Supplemental Insurance, was reviewed, highlighting its role in covering gaps in Original Medicare, the rules for enrollment and guaranteed issue, standardized plans, coverage for Part A and Part B cost sharing, and interactions with Part D. We clarified new rules for individuals who became eligible for Medicare after 2019 regarding Part B deductible coverage. Finally, we explained how Medicare coordinates with employer group health plans, distinguishing between large and small employers. Large GHPs generally pay secondary to Medicare, but must offer equal benefits to employees age 65 or older who are still working, and employees may delay Part B enrollment without penalty. Small GHPs allow Medicare to pay first, and these employees should generally enroll in Part B when first eligible. By understanding the different parts of Medicare, how eligibility and enrollment work, cost-sharing responsibilities, assistance programs for low-income individuals, Medigap rules, and coordination with employer coverage, you are well prepared to navigate Medicare effectively and succeed on the exam.